It will tell you if your A1C is too high. It'll tell you if you need colon cancer screening. It'll tell you need lab tests, and it'll actually tell you where to go to get this stuff done. It's not just telling you what's wrong, but how to fix it. We found this hugely engaging to our patients, and they fill their care gaps actually better than when they come into our offices. Last piece on this, we did a study in Health Affairs showing patients who go on and use our secure email system to their doctors actually have an improvement in control rates for A1C, LDL, and blood pressure. This is a matched controlled study. I wish we could have randomized, but they wouldn't let me. If anyone wants to do their own randomized study, look at this first and it'll give you a clue on sample size calculations. But getting patients emailing, I think, is more contacts with the system and they do better. It's another way to engage people. So with that, I wanted to just mention we have 13 medical centers. We monitor the performance of each one of those. We were seeing San Diego was going along doing reasonably well, but we thought there might be some opportunities, and so we touched base with Dr. Bogany, and she's going to tell you what happened next. So thank you.
Oh, that would take a moment, huh? Please. And so, why don't we do a stretch break in keeping with earlier theme, right? So, there we go. Is that Hattie over there? Happy to hear that. Everybody stand up, please. And then, Michael, do I get the, do you have the mic or no?
I don't have a mic.
Oh, we have the lapel mic?
Mike doesn't have a mic.
There's no lapel mic? Oh, all righty. So everybody reach for the sky. Where's Jerry? We should put Jerry up here on the spot after he helps. Jerry around. Yes. Oh, there's Dr. Mario, our cardiologist. Put him up here. I've been telling everybody, pay back. Oh, thank you. Yes. And so, do today's work today. All right, everybody stretched, arms, we can bend over, touch your toes. I don't want to take much time. Do what you need, run in place, anything like that. Some workplaces, who are those, the big computer companies, they actually sit on those exercise balls and all the treadmills while they're working. So if it gets our brains thinking. So excellent, Michael, thank you so much. So the mic wasn't on when Michael said that clearly you kind of got a preview of my personality. I don't really stand behind the podium. So if that's okay, I will come from behind the podium. And so you didn't hear me actually say it, where Michael Cantor and his team, his quality team, came down to San Diego. They come down yearly, and they came down about 4 years ago. I became the physician director of complete care management, so leading the outpatient quality in San Diego in January of 2010. Shortly after that, he came down with his team, and he was so kind. He said they were not doing well. Well, with the 13 areas, San Diego was towards the bottom. I don't remember 13, 12, or 11 in Southern California. And San Diego's a Navy town. Any military? My husband's military. That's what took us to San Diego. He's active duty in the Navy. And so with the military town, San Diego's an aircraft carrier to some of the other areas in our Southern California region. 537,000 members. Currently, 112,000 of them have hypertension. Diabetic patients is up to about 44,000, just to give you a preview of what numbers we're dealing with. I'm a numbers person, and that's what Michael and Jim have learned about me, that I am a little bit unique, like all of you here, liking the numbers, and with Dr. Yu, with the numbers and the quality and the outcomes. And so on that note, with San Diego, what we did was implement, because Dr. Cantor and his team publicly flogged us, and we were quite embarrassed. And so the improvement process, some of you at the Right Care Initiative in San Diego may have seen these slides. And so it looks simple, and earlier we had the discussion with the questions at the beginning. This is scalable. So we have 537,000 members in San Diego. Well, then we're going to have a lot of physicians in San Diego, about 900, 254 primary care physicians. So that's a lot. And so scalable. Yes, we're huge. We're an aircraft carrier, but there's still yachts out there and boat houses and jet skis and all of that, right? So scale it down. Data. It's the what? The numbers. And the numbers do drive. We've heard that, right? The numbers drive behavior. The staff education's the why. Teaching the staff, we've heard a lot about that today. And provider education. Really for the docs, what's in it for me? Because the perception is we're giving them work. We're changing that culture, not that we're giving them work, we're trying to make their work what? More efficient? Yes, more effective. So the process change. Do we all do this when it comes to blood pressure checks? Relax patient, feet flat on the ground, arm at heart level. And how many of you do the standing blood pressure if the patient's over 70? Yes, audience participation is not an option. I know Hattie. Okay, just one area other than Kaiser. Just one? I just saw one hand. Okay, so that's pressure up. No, pressure down, measure up, right? You got it backwards. So to have that standing blood pressure. And so staff education, a lot of academic detailing we've talked about. In Kaiser, we call it the proactive office encounter. So the POE alert. Yes, we do have the electronic medical system. No, we're not perfect, or our numbers would be 100% in everything. So the electronic medical record does not solve it all, however it helps. However, the key is at the bottom, the unblinded data. We've all heard, yes, unblinded data today. Very important because we are a competitive profession. Very competitive. How many of us like sports? We talked earlier about football. There's the Baseball World Series now. I love soccer. My 9-year-old plays soccer. Competitive, right? So San Diego needed to make changes. Outreach. So with Dr. Yu, and now I'm going to put Dr. Cantor and San Diego, we actually do robocalls, we call them, KPNS system, and it's my voice on a recording, and they behind the scenes, the IT people, set it up so it spits it out on a regular basis. And it does drive and motivate my patients to come in. They say, yes, you called me, I got your call again. And the letters, the same thing with those certified letters. Then it's the academic detailing with physicians. Physicians don't like to be publicly flogged or embarrassed, so you sit down, what I call, are the pharmacists still back there? Those pharmaceutical drug rep rounds. And so you just pop in, and the doctors on the healthcare team motivating, and it's that unblinded data, and we share. Do you see at the bottom reference to Kaiser Woodland Hills? So we do share within Kaiser, and here today outside of Kaiser. And so with this, the hypertension algorithm, which you saw earlier, and this gets the Jim Duddle stamp of approval there for presenting this. This is his work. Oh yeah, it's got your stamp there, Jim. The PowerPoint, love to play with that. And so in San Diego and in Kaiser, we do well in hypertension. So how can we continue to do better? And so that's what we just hear, right? We want to do better. And so we realized there was the healthcare disparity. And in San Diego, we have now about 8,200 African American patients diagnosed with hypertension. I actually feel that that's an underestimate. Why do you think that would be? Like Mr. Gomez, do you think they even come in to get a documented blood pressure? So it's probably an underestimate. And so we're going to get more patients with the Affordable Care Act. However, we have 8,200 patients. So then we say 8,200 patients, African American patients with hypertension. However, we have 112,000 patients with hypertension. So that's what? Really kind of cherry picking. So convincing the other physicians and the specialist that it matters. So specialists were involved. Everybody got the low sodium handout in all departments. They were given out if the patient had hypertension, not just African Americans. So what happened? Hypertension rates are going to increase, and the control and the disparity will close. We've reached out with letters with pictures of primary care physicians saying, time to come in, your blood pressure's uncontrolled. That was stolen from Kaiser West LA, where we have the largest African American population. And then Downey gave us large group classes, so we call them group visits. There's no copay. We have an African American nurse, health educator. We have very few in San Diego African American physicians. And so guess who gets to greet most of the classes? And so that would be me, but I don't mind. Clearly, I'm not kind of shy behind the mic or anything like that. And so it had mixed results because of the motivation of the building to get the patients in. So last week I had a class with about 13 patients, 2 had high blood pressure, and they were really impressed with the focus on African American hypertension patients. Now when we talk about the community involvement, so we have the resources within Kaiser. However, with Right Care Initiative, we're working on going outside of Kaiser and into the community. So a church, a school, to hold these events so that more people can come and less resources needed. And so this was 2007, 7 years ago, we talked about equal opportunity. And now, how has that changed? What's the new language? Rather than it being equal, it's what? It's in bold letters, capital letters. Is it equal or is it, equal or equitable care? And so that is the new buzzword, right? Equitable care for all. And so Trevor Wilson, and this is what it's about, equitable care. And so there are multiple actually disparities. And so African American hypertension is one, and then women with cardiovascular disease. And since we are here also discussing diabetes, the Latino population, we heard that earlier. And so that focus, and actually steering your focus to that to continue to save more lives. And that's why we're here. Clearly, I enjoy what I do, and I'll take the show on the road so that anyone, if we just save one life, right now, if each of us could convince and motivate Mr. Gomez to come in, what we would do as far as his quality of life, the cost of health care, et cetera, et cetera. And so I believe that is almost it. So we have the equitable care and health outcomes. So we do have that located in Northern California here. And this is where we did a CME, 1 hour CME for all primary care physicians. Yes, I have the PowerPoint. Yes, I have the audience response questions. To contact me and I will send it to you. And so, because why reinvent the wheel? Why reinvent the wheel if it's already there? And so I'm a full believer in that. And so the handouts are actually, I'm not sure if they've come around, you'll see some of that info. And so that's what it's about. That's what it's about. The time is always right to do what's right, not to wait for tomorrow. As Michael Kander said, to do today's work today when the patient's in front of you. As Parag said, yes, how do you accomplish all of that in 20 minutes? I don't. I wish I could see one patient in 20 minutes, but I couldn't tell you the last time I saw a patient in 20 minutes. And so I appreciate your time today, and to Hattie, and to her leadership team, and to Liz and all of the behind the scenes to allow us to share just a little of what we do to motivate patients with our Kaiser system. Yes, we might be at an advantage, however, this is scalable, and we're here to help you. Because who knows, my family may move to one of your areas. A friend, and that's what it's about. Okay, any questions?
I do have one question for you, Ray. And that is, can you talk about what a difference it made to have the mentor of Jim Duddle in San Diego helping you along?
If you give me a second day. And so I need a whole day. And so, yes, you see Jim respectfully declined from speaking. You've heard a lot about Jim. And yes, Jim is an endocrinologist who worked in San Diego, still lives there, and now works with our Care Management Institute in Northern California, sharing all of his knowledge and his successful practices. And so one of my partners in crime, Yvonne Plowman, is a pharmacist, and so we work together with Complete Care Management. And she worked in our cholesterol clinic with Jim Duddle umpteen years ago. So Jim remembers when Yvonne was this little and how they worked together to improve San Diego with cholesterol control. And so his mentorship, his knowledge, his experience, just a multitude of wealth. And he doesn't mind being seen in public with me, so that's a plus for me. So thank you to Jim. Thank you to Jim. Thank you to Michael. Thank you all for having us.
And thanks for all your hard work turning around that lower
That
performing
area.
entity. Yeah, that was really awesome turnaround from this team.
Thank
And
you.
that's what it's all about. That systemic approach that Michael Cantor talked about, it can be applied, and it's about leadership deciding to do it. So with that, we want to bring up the next set of speakers, and Dr. Kohatsu, could you also join us at the table?
So our next So we're headed to our last two sets of presenters before the award ceremony, which is very exciting. We're going to take a little bit of a turn and talk about a couple of issues related to technical assistance. Health Services Advisory Group is the quality improvement organization for California and has worked with many practices, including many here today, on improving diabetes and cardiovascular disease outcomes. Today we have Dr. Mary Firmason, Chief Medical Officer of Health Services Advisory Group, and Dr. Gil Simon, who has worked closely with Health Services Advisory Group. Dr. Simon is the Medical Director of Sacramento Family Physicians, here to join us today. In addition, after Dr. Firmason and Dr. Simon speak, we'll be hearing from Dr. Kohatsu, Neil Kohatsu, who's the Chief Medical Officer for the Department of Healthcare Services for California, as well as Dr. Desiree Bachman, who's the Chief Prevention Officer at UC Davis Institute for Population Health, and their focus is going to be on Medi-Cal blood pressure quality improvement. Thank you.
Thank you. So you've heard all throughout today about medical groups and integrated healthcare system, how they improve care and achieve the goals of the Million Hearts campaign and improving diabetes care as well. Now you're going to hear a little bit about more about the small clinics, independent clinics with no QI infrastructure, and how do they improve care. So I've known Dr. Gil Simon since my Medi-Cal days. He started his first clinic in 1989, correct? And he's dedicated his life to serving the poor, the minority, and the underserved population. And since 1989, he has built has now 8 clinics and is serving 35,000 active patients, I believe. He's been named the health hero by the state of California. So the HSAG, which is the Medicare Quality Improvement Organization, we have been contracted by Medicare to improve care for Medicare fee-for-service beneficiaries, especially targeting the providers, physicians, hospitals, nursing homes, and others that are needing help. So the small independent practice physicians, the small clinics, and so forth, and those who are performance have opportunities for improvement. So we started working with Dr. Gil Simon 7 years ago and improving the documentation on his measure specifications. And in the last scope of work, we started working with him on improving care for his cardiac patients. Specifically, we help him implement the Measure Up, Pressure Down campaign, and also get his patients who are at high risk to participate in a patient engagement strategy that we have, where we engage them in self-care education for about 8 weeks, and this was in partnership with the American Heart Association. And so, through that work, you will see the results that Dr. Gil Simon will present to you. At this time, though, I would like to say that HSAG is also recruiting, currently recruiting physician practices to work with us so that we can provide free technical assistance and other assistance to them to improve care. So, Dr. Gil Simon?
For IPAs, the IPAs in the room could particularly probably benefit from the free technical assistance from the Health Services Advisory Group. And so that's a nice federal benefit, actually, to talk with Mary about at the reception.
Okay, Mary, thank you very much for that introduction, which I think I wrote. So very, very nice. This is what our mothership looks like today. This is one of our 8 clinics, and this is how it appears, minus the graffiti. We began this 25 years ago. We're now ending 25 years of service with this mission. And while you're reading this, see the similarities between this mission and the mission of best practices. And I'll also give you a little talk about how Medi-Cal differs from the rest of the other insurance programs. The first place, half of our patients don't speak English. Half the patients turn over every 12 months because it's open season every day in Medi-Cal. The Medi-Cal payment structure is a disgrace. It's a national disgrace, but we have to live within the limits of that. Our patients typically have a 5th grade literacy level, but their health literacy is below basic in 53% of the time, which means that most of them have difficulty reading the instructions on their prescription bottles. So these are some of the challenges that we've had to face, and we face them happily because we have such an opportunity to provide a helpful impact on this community. So. Where's Gordon Wright? Gordon Wright, is he? Here's Gordon. So none of this would be possible without Gordon Wright, who is our HSAG consultant. And all the numbers I'm going to show came as a result of Gordon's efforts. And I want to thank you publicly for all the help you've given us. So here are some of the quality programs that we've done with HSAG. And beginning 10 years ago or so with the PQRS and the meaningful use, measure of pressure down, and then the scope of work for the last 3 years. So he's played a very important role with us. Here are some of the numbers. And any number that's to the right of a dollar sign is a very important number. So over the last 3 years, to date, we've received in meaningful use funds $314,000, and that's gone a long way towards offsetting the considerable expense of electronic medical record keeping, and we have many more dollars to come this year when we get more people to attest. So we did use our information provided for us to benefit our Measure Our Pressure Down program, which we undertook several years ago, and it was a no-brainer for us. The planks that were required were easy to walk for us, and as you can see, directing the staff to take a blood pressure accurately was a joy for me to teach each of my medical assistants how to do it. They take great pride in their prowess in taking blood pressures. When they record blood pressures in the records now, they write next to it, patient hasn't peed in 30 minutes. Or they'll write down something indicating that they really thought about taking this blood pressure accurately. They're very proud of their blood pressure readings. And we always take blood pressures at every visit, so that was no problem either. We knew the guidelines. We didn't know whether we were to take the JCN 7 or 8, but we stuck with 1. And we got the patients to come back every 2 weeks until the blood pressures were taken. So none of this required a great deal of technology. It required a great deal of touch. And we have great medical assistants to provide that touch. And that's been the secret weapon of the SAC family. We have a very large, very committed group of medical assistants who live and pray and shop in the same neighborhoods that our patients live, pray, and shop. So they're part of the community, and many of them were patients of ours. Some of them were children who I raised when I was taking care of them as their pediatrician. So they're very attached to SAC family, and they're very attached to the community. That's our secret weapon. We don't do robocalls, we do personal calls. And we see them in the streets, we see them everywhere we can find them, and we talk to them about their blood pressures. So with that approach, here are our results. We began this in the first quarter of last year. And for that quarter, our control rate was 49%. And then every quarter thereafter, the rate kept increasing. And as of the data that Gordon produced for us a few days ago, one day ago, the rate was 72%. So we're rapidly approaching the 80% limit. This is all the results of the close contact that our medical assistants have with our patients. So, do you have any questions? Yeah.
Would you please elaborate on the close contact that your MAs have with your patients? I think that is definitely, in addition to your own persistence and passion, a key to your success.
I didn't hear much of what you said.
Tell us more about the connections that your MAs have with your patients. In addition to your persistence and passion, I think those connections that the MAs have, how you've worked them into the organization, worked them up, mentored them, and they maintain their connections in the community, I think that is a major factor in your success.
Right, maybe I didn't explain that well enough. That is our major beneficial factor, and our patients spend more time talking to our medical assistants than do to our clinicians. So it's our medical assistants who are the ones who encourage them to take their medications and encourage them to come back in 2 weeks and remind them. And when they don't come in, they call them and say, "Where were you? We wanted you to see you today because your blood pressure is still elevated." So it's that very personal connection between our medical assistant staff, who really come from the same cloth as our patients do in that community. So there was no need to bridge a gap. There was no gap to begin with. Our medical assistants and our patients are all the same people. So there was very little difficulty in getting that connection made. I think that earlier today we heard about the attributes that are required to make changes, and one being the desire for mastery. Our medical assistants are so thrilled with their mastery over this technique. When I taught them how to do it, it was a surprise for many of them that the patients had to have their feet firmly on the ground and they had to have their arms supported and heart level. They were very happy to hear that, and they believe that they're the best blood pressure measurers around, and they're very happy with that. So that, plus the connection, plus the motivation, has made this a successful program. We still have a little ways to go, and we're not going to stop until we get 100% blood pressure control. Anything else? No?
Now we'll have Dr. Kohatsu come and share with us the Medi-Cal program's quality improvement efforts.
Thanks very much. In light of the hour, I'm going to probably cut my remarks in half. And our focus is really on the Million Hearts Initiative, not hypertension alone. And but let me just give you a quick overview of what we're doing, and I hope it'll set up for our last speaker. One of the key components, and this has been talked about all day, underlying all the work that we do in terms of the clinical domains and medications, smoking cessation is fundamental. We're in 2/3 through a $10 million CMMI grant on smoking cessation, looking at the impact of incentives. I'll just quickly say that based on 2 randomized controlled trials, there's strong evidence in our Medi-Cal population that incentives are quite potent and relatively modest incentives, $20 merchandise cards and the like. We talked from the beginning and actually in several of the examples about the importance of policy. We are certainly focused on what I call the full court press, both in terms of centralized policy and that with the health plans to really get an aggressive approach to smoking cessation, not only individual group and telephone counseling, but targeting high-risk groups as well. We've talked all day today about variation in hypertension control. I'm not going to go into details except to note, as we've heard, it's been a very amazing story in the Kaiser system and other systems throughout California, but Kaiser, you can't see because of the font, but Kaiser San Diego and Kaiser Sacramento lead considerably up, approaching the 90% control range with the HEDIS metric, and this is in a Medi-Cal population. So the great variability says that we need to do a lot more. The Kaiser benchmark says that we can do a lot more, and systematically using the techniques that we've talked about today and the policies, we will get there. We're working with our partners at CMS. We're part of a national learning collaborative in hypertension. We're working with our colleagues and my colleagues here in the managed care division, have a collaborative with the health plans. So we're going to be learning from those who are setting the benchmark and those who are committed to advancing and improving in terms of performance in hypertension control and are setting group targets similar to what you've heard earlier. An area that we haven't talked about so much today, but is an area through the Million Hearts Initiative where I think there's a lot of potential is low-dose aspirin. Our preliminary data, as has been shown in many systems, is that low-dose aspirin has been underutilized, very effective. Obviously, there's some nuances to use aspirin effectively. It's not for everybody, and therefore you need to pay attention to how you implement that. But we're probably going to launch a pilot in one of the health plans or several of the health plans to address aspirin. So just wanted to demonstrate that we're committed in a system that takes care of 10.5 million members, probably going on 12 million when all is said and done with expansion. Almost a third of Californians will be Medi-Cal members. We're committed to the Million Hearts Initiative and to learning from the collaborations that we've heard about throughout the day. So I'll be happy to take any questions and leave time for our last speaker to talk more about Million Hearts.
That the Medi-Cal program is going to take on the blood pressure so that we're aligned.
Thank you, Hattie.
Thank you, Neil. So
Our final, you want me to?
No, go ahead.
Our final speaker of today is going to follow up talking about the Millions Hearts campaign and some of the milestones and objectives of the initiative. So I'd like to welcome Laura King-Kahn, who's a nurse with the Millions Hearts campaign of the American Heart Association. Thank you.
Thank you, everyone. It's so exciting to be here. Today is no exception. I have always found over the last 3 years that I've been engaged with RightCare that I leave the meetings feeling enthusiastic, hopeful, reinvigorated by all of your hard work each and every day, and today was no exception. And so everyone here, really all of your work is about the patients, and then we've heard that throughout the day, but I just wanted to give everybody time to sort of think about that and reflect on it as we sort of segue into the last portion of the day. I know we're going to have a reception after this, but I just wanted to congratulate to each and every one of you for all of your hard work. This morning you got to hear about Million Hearts. Nicole Simon was here to speak about the program